Yeah, give them a history.
I will, history. Well, gosh, where do I start? I was born in Brooklyn, New York. Yeah, we start way back there. And during high school, I ran track. I actually, at one time in 1956, I was the Eastern States Champion Cross Country B Division. A Division I couldn't quite compete, but I did win the B Division. Somebody saw that and said, "You need to go to the Naval Academy at Annapolis." I said, "Okay, I'll go," which I did, and went through 4 years at Annapolis, graduated. I spent 2.5 years on restriction, coming from Brooklyn and all. I was a bit of a juvenile delinquent, so I got commissioned into the Navy. I spent 10 years as a carrier pilot. I have 300 carrier landings. That might sound like a lot, but there's people who have lots more. There are people who have 1,000, but everyone counts. It's the one you can walk away from, that's good, but it's better when they can use the airplane again. So, during my naval career, 1966, and this all will tie in, I promise. In 1966, I was ready to go on my first combat cruise on the USS Saratoga. I was coming home through downtown Jacksonville, and it was the night before the ship was due to depart. All my gear was on board. We were ready to go. And some guy jumped the median, and I was doing 50, and he was doing 50, and he hit me head on. Amazing. Here I am. That, in my life, was my first God wink. Anybody know what a God wink is? God wink is when you tell God the plans that you have for your life, and he laughs. So he said, "No, Tony, you're not going on this combat cruise. I'm going to put you in the hospital because you got your whole body tore up." I had a comminuted fracture of my right femur. They told me about 100 and some pieces in there, little chunks and pieces and stuff. It was about that much separated. I can remember laying on the gurney and watching these lights going by. And they said, "We're going to have to take his leg." And, you know, I'm got full of pain medicine and all that. Lieutenant Commander Gilchrist. See, that's the ones I want you to aspire to be. He said, "No, I think I can save it." So, where's, Todd, where's the picture?
You want
The first one.
Yeah.
this one?
Yeah.
Be up on the screen
Oh, okay.
Oh,
Upside down.
and blue.
So there I was.
I'm gonna focus it for
There I was in Navy Jacksonville Hospital in traction for about 7 months. And in traction, if you notice, and get out of the way, that's my right leg sticking out. I mean, it's out here. And what they did is they had me in traction so that the bones, the calcium, I was still young, I'll be 26, 25, so that all the bones knitted together. And after traction in that, you know, you're in the bed for 6 months. I couldn't move. If I moved my leg, all those little nerve endings, they were really painful. That was about 90 pounds of weight that was hanging down. So they put me in a body cast, and it had a bar between it so I could pick it up and move it. First thing I did is I tried to go to the restroom. That didn't work out too well. But after the body cast, then it was a half cast. Then it was around the waist, down this leg, and down that leg. And then they put me into a brace. And that is where I had in the back of my mind in 2014, as I went through this process with the ankle, man, something's got to be done for this. There can be something. So there's my brace, and it's similar, and it took all the weight off of the femur, put it on my tailbone, and I was able to walk, which is wonderful.
Pause.
Go
What's
ahead.
that called? He used layman terminology. What is it called that he just described? Where's it going? Ischial weight bearing KAFO, right? So he said tailbone, it's ischial tuberosity. Okay, so that's ischial weight bearing KAFO. So in our speak, when you speak to another therapist or an orthotist or an orthopedic surgeon, that's what that's called. Okay.
Good, thanks, Rick. So 9 months later, I'm at Saratoga coming back from the combat cruise. The pilot that they sent to replace me did not make it back. So there was my God wink. So I resumed flying, and about a year later, I had another mishap. Somehow, I have mishaps. I have a history of two-wheeled vehicles. Well, this was in an airplane. I had to jump out. I ejected on the runway after landing. Well, it was on fire, so it was time to go. And I only had one gear, so it was starting to go over, so I punched out, and I broke that ankle. So they put me in a cast for that for 6 weeks. It healed, and I went back to my normal life. I got out of the Navy in 1970. I worked for Delta Airlines for 28 years. I retired as Director of Pilot Training for Delta Airlines. And during those 28 years, plus 10 or more, I just led a normal, everyday life, doing the things pilots do. And, you know, pilots have a lot of time off, so I took up golf. And I don't know if you can see, I can swing pretty good with this. Not real good, because the weight on that. But every time I get on the golf course, or anyone gets on the golf course, you walk around, and what do? You step in holes. Every time I stepped in a hole, it was with this right ankle. It would buckle. I would say, God, thank you, it's my bad ankle. So, because it was strong. It was broken once, got healed, and it was pretty strong. But when my leg first was set, it was offset. My leg was 1/2 inch shorter as a result, and I never knew it until that day in November. I was playing golf in Orlando. I swung, coming down a little incline. I could not move my ankle. I was done. So I got the cart, they drove me home, the pain went away, and I went to see my orthopedic surgeon. Took an x-ray, and he said, well, you know, there's 2 joints in the ankle, the upper and the lower. We can replace the upper, we fuse the lower, and you'll be on your way. I said, okay, that sounds reasonable. How long will this take? He said, once we do it, it'll be 3 months, no weight on your ankle. I said, uh-oh, that is not gonna work. And the reason it's not gonna work is my wife is a cancer survivor. They did brain radiation. She needs pretty much constant care. So if I'm three months no weight, you know, who's gonna feed us? So I declined to do that. I walked around like this until July of last year. July of last year, she was in PT, going through her physical training, and I was sitting at Florida Hospital Memorial, Oceanside, down in Daytona Beach. As I normally do, I watch people, and she's over there doing her thing. And these 2 people walk up, and they have visitors tag. And one is Rick Coleman, and the other is Joey Stevens. And they have these visitors tags on. And since I own the hospital anyway, I am on the board of directors, I'm nosy. I want to know who's visiting my hospital, what they're doing there. So that is when I got a shoulder tap. You know what a shoulder tap is? Is when God says, hey man, go do something, whatever it is. So he tapped on my shoulder. I said, hey guys, what are you doing? And they said, well, we're here to meet.
We were meeting the physical therapist
Yeah.
there. We were doing basically marketing. I was marketing to you guys. So
Yeah.
when you're out there, you're going to see guys like me that come in and try to, you know, make a difference and get business from you.
Mm-hmm. So that's what they were doing. I said, well, okay, tell me your story. They told me the story. And I said, well, I can introduce you, because it didn't look
Okay,
like
I'm
you
gonna
were.
I'm gonna interject my portion of the story. So it's great because it's perfect. So I walk into the hospital and I see this gentleman with an ankle rolling, and I'm not there for orthotic work. I am there to find amputees. That's my modus operandi for the day. I'm out trying to drum up prosthetic patients, okay, because that's where the money is. So I'm in business. I want to go make money. So I see him and I said, oh, he's rolling his ankle. And so I walk by him, just like, hey man, what's up? How you doing? And so I walk over to the view out the window, the beautiful hospital, beautiful beach,
Right on the
beach, looking at the window. He says, yeah, not many people have a view like this. I was like, no. He says, so what are you here for? I was like, I'm here to talk about patients. And he says, oh man, great. He starts, I was like, oh, prosthetist, awesome. Take a look at my ankle. I'm like, okay. So I'm roped in, right? I'm lassoed in. And I start talking the game. I start evaluating. I start talking to him. And lo and behold, he becomes my patient.
No. You said,
I
can fix
you.
that.
Yeah, I can fix it.
And I said, bull.
Calling me out. So when I saw him, there was one key question I asked, and I think you might remember exactly what it is. I said, does it hurt when you just stand and weight bear? Just putting weight straight through your ankle, is it painful? And he said, yeah. So what do I have to do in that scenario? Similar to that. I gotta lift him off the ground. Okay, I gotta de-weight the ankle. So when,
Time to put this
yeah,
on.
sure. So
Go ahead,
come on
you keep
up, come
talking.
on around. He's gonna sit down and he's gonna don his, did you bring long socks?
Yes.
Awesome. No. So when I saw him in there, the key question I asked, and I could see his ankle was rolling, and I said, okay, if he's got pain during standard weight bearing, just static weight bearing,
See without the shoe.
right?
Here we go.
Right? You can see it roll. Yeah. All right. Okay, let's not.
I'm good.
Let's not.
I get along at home pretty good.
A fixed deformity as a result of all the breaks. A fixed deformity as a result. No fusions at this. Patellar tendon bearing AFO. PTB AFO. All right. That's patellar tendon bearing. That's a little bit of a misnomer when I'm concerned and when I'm speaking about it, because I don't strictly load the patellar tendon. I'm not bearing all the way through the patellar tendon, but instead I make mine very long. Grab me that one right there. Okay, I make mine very long that goes down past the calf belly. All right, so one of you guys might be able to try to put this on today, actually. This was my mom's. I made that for my mom. So you can't. So when you're treating people, obviously it doesn't get limited to people you don't know in the beginning. When I make this device, I don't necessarily want to squeeze really pointed areas because he's got to bear his whole body weight through this. So I try to make it long and get up under the calf belly and lift him up. You can see this one has the screws in it that you can telescope it. I don't know if we put telescopic on his. I intentionally basically lifted him off his foot about 3/8 of an inch so that as he bears weight, he touches but not hard. How much, if you could say how much you think it de-weights your ankle, how much do you think it de-weights your ankle? Like
All of it.
all of it. You don't hardly feel pressure on your ankle.
Nothing. Zero.
So,
What do you want to see me do?
right? Right?
There's lots of things I can, lots of things I can't. The things I don't like about it, I have to bend over to tie my laces. I get this thing here and it's Second, I cannot walk on the beach. I used to walk on the beach every day for an hour. I can't do that. I can't do that with the brace. I can't do that without the brace. If I do it with the brace, the shoe gets ruined. Salt water just eats that thing. And the third thing, I can't run. I didn't run before, so that's okay. No problem. What I can do is anything else.
Watch out.
I'm good. I am good. I have full balance. Oops, yeah, Rick.
Right?
Oh,
yeah.
Nice.
100%.
So his backswing, he puts all his weight through it. So
Yep.
big problem for an inversion problem when he goes into his backswing is a right-handed swing.
I'm good.
He's going to roll that ankle like crazy. So when I de-weighted his ankle, there's no pressure to put down to roll it into inversion.
Right.
Right? So we've corrected both problems without having to do anything else.
When I take this off, my ankle is stable for a short period of time. So I can just walk almost normal until it starts hurting again. So what I like about it, it has absolutely changed my life. I can walk every step with no pain. I could just be normal. And thanks to this gentleman, when it breaks, and it does, because
Yeah.
I'm not easy on
No,
it.
he's not.
I call him. We have two pair of shoes. I got a white one and the black one. And he'll come and we'll fix it.
So look how skinny this is.
Yeah, look how,
Okay? Look at his.
I've got a double.
Literally had to weld two together.
Yeah.
He was snapping them because the golf issue puts that torsional transverse plane torsion through those points, and he was literally snapping them. So we have modified that extensively in order to disallow that and to keep it as functional as possible over a period of time. What's the other thing that's done to this that you might be noticing that's not necessarily done a lot on this, but look at the shape of that shoe. That's a bit rockered, right? So that's the same thing. So as he walks, he's still got some ankle range of motion though, right? Because he still has some strength there. And all I really wanted to do was lift him off the ground, but I didn't necessarily want to limit his dorsiflexion and plantar flexion. Okay? So he has some range of motion in his ankle. Yes.
Which is adjustable.
Yep.
You also add the heel lift for the leg length discrepancy as well?
Yes. Well,
on
that
this
was-
one, yeah, he's already short on the side. Were you already short on
Yes.
the right leg?
Yeah, there's my half-inch
Yeah, so-
on my old tennis shoe.
I got lucky
Got all
that
my
way.
shoes.
Okay.
Right? I got lucky that way because I didn't have to add a lift to his left leg. His right leg was shorter from all the injuries.
Uh-huh.
So we just built in what we had. We had plenty of room to work and didn't have to do anything to his left shoe.
Right.
Right?
So there you go. That's God wink,
Right.
shoulder tap, all rolled
He said-
into one. Wow.
Well, and the truth of the matter too is that he has another shoe, the white set, not
Right.
these,
Just like this.
right? That are just like that. That I have another stirrup built into. So he can literally pop this loose himself and put his white shoes on. He's got the capability of doing that. He does it. Do I do that with everybody? No, right? He had to pay out of pocket for that because it was not covered by the insurance. A second set of shoes with a second stirrup, not covered. One device, one setup, that's all you get. Is permanently attached, just like we just said. The stirrup is permanently attached to the shoe. His stirrup goes about out to here. It goes all the way out to the met heads and allows him to lean into the brace. So when he wants to really just use the front shell, he can lean into it. You can see it bending right here.
I can.
Right? And he can really put some pressure into that to get that toe lever that you don't normally, aren't able to get with this setup. This can lift you off the ground, but the shoe will fold up and this will just tear up a set of shoes and with quickness. So I tend to make them long.
And there's also the screw adjustments that I can adjust, the flex of the ankle. I have it just enough so that I can just push down on the gas. And of course, I can't put this on the brake, so I had to learn to drive using my left foot as the brake. And that took 10 minutes. So my wife every now and then says, "Well, why are you stepping on the brake so hard?" I said, "Well, because I can. If I don't, anyway." So, but that's the story. I have a normal life. I don't have to worry about surgery. 3 months, no weight on my ankle. What that would mean is my wife and I'd have to go into assisted living, so they could take care of me and take care of her. So I have put that off not only indefinitely, but hopefully forever. So there you
So
go.
when they do a fusion on an ankle like that,
Oh, yeah.
the subtalar fusion, right, under the talus calcaneus, they're locking up the inversion eversion. What else does that affect? It's going to affect the joints on either side, no matter what. Both sides of that are going to be affected because the heel doesn't have the motion, so now that motion is going to get taken up in the midfoot and some in the talocrural joint that's just going to get translated up into that. So it's not going to last nearly as long. So we got really, lucky when it comes to being able to treat him effectively, and thankfully, he was willing to wear it because a lot of people aren't, my mom included, okay, didn't want to put up with it. All right. So you end up with patients that will be a success and patients that won't have success with a particular device. So don't expect the world from these things by any stretch. They are a challenge to wear.
It took me about 5 steps.
And he's got a fabulous attitude. Okay, so his attitude is amazing, so he's going to do well. But it's all about wanting to do it. Yeah, the mental portion of it.
Any questions? What? Anything?
Come on, guys, you got something?
Sure.
What do you do when the shoes wear out? Like, does insurance pay for just the new replacement shoe, or?
He would provide me the shoe. Since he's not diabetic, the insurance is not going to pay for a set of shoes. They have to supply the shoes typically. That's a Medicare rule at this point.
I will tell you in my case,
Yeah.
I have shoes probably from my Navy days. I don't wear shoes out.
Yeah.
So I'm good. These are for the
And
long haul.
And as the
yeah.
sole, if the sole gets torn up on it, then we can replace the sole. That's a high quality shoe where we could strip the sole off and put a new sole on pretty easily.
You have a different sole on my white shoes. you have resoled the front.
Right, we put a layer of material that was not the original material.
Uh-huh.
So obviously a success case, which is great. There's another example of a long tongue stirrup. Okay, so that's how much length I'm talking about. Obviously this was made for a very, very wide shoe where we cut one in half and split it and put two together. So lots of custom things can be done for whatever purpose we need to achieve for the patient. Anything that you can come up with is something I can probably build. That's the goal.
This
right?
man
So-
is an engineer. I'm here to tell you.
All right.
He is.
So let's take it off. Let's watch him doff it, take it off, so that we can watch him reapply it as well. I want you guys to really pay attention to the design. When you get out in the quote real world and you have a PTB AFO made, they do not always, they aren't. Almost never are they built like this.
No.
What's very special about ours that we do is I put this long strut here, and I have, over the course of years, made it longer. Because he's got to get his, it's a big ring, right? He's got to get his foot down through it. And you can see this is different in that regard. We put ladder straps on my mother's. But you can see that strut there is much shorter, so it's harder to get your foot down through there. And then imagine trying to get your foot into the shoe and get it all lined up. So he just took it off really easily. He's super good at it. It wasn't quite as easy in the beginning, but because he's such a trooper and says, yeah, I can do it, he makes it easy, easy on me because he just does it.
Let me say something about the doctors.
Please.
You just mentioned something. I first went to the doctor, the ankle doctor, and he's outstanding. He is an orthopedic surgeon. He studied under the doctor up at Duke who invented the ankle replacements. And when we went through my diagnosis and treatment plan, he never mentioned a brace. I mentioned it to him based on that picture, what I knew was possible. And he didn't know a thing about it. So I went all those months until I met Rick and Joey, and then I got the brace. When I got the brace, I took it in. We have an orthopedic center of excellence down at Florida Hospital Flagler. And Dr. Alter, he's been there for 25 years. Awesome. I brought it in and I showed it to him. I said, hey, Denny, take a look at this. He said, wow, where'd you get that? And he went through all the different things that it was. I said, you knew about this? And he said, yes. And I said, well, that's 14 months of pain that I walked around because Corey, my doctor, did not know about it. So it's communication, it's knowledge, it's training, and application of all of those. Anyone missing, you got somebody like me that's gonna walk around hurting or not hurting. So when you get out there, just because you're gonna be a physical therapist, do not be afraid to communicate. Do not be afraid to tell the nurse, tell the doctor. This is what I think. Even if they give you crud coming back, you just do it. That's your job, is take care of your patient. So, any other questions?
What was the hardest thing to get used to with the brace or the orthotic?
No pain.
That was the hardest to get used to?
Actually, I've got a video someplace, they put it on, I took 5 steps with the walking stick, and I was done.
You knew then?
Done with it. And I walked, came back, and
Yeah,
We were done.
I mean, obviously, his
there was
attitude is amazing,
absolutely,
so it makes a huge difference.
the little things, the driving, just to get that, just to start with. But as far as any kind of adjustment to lifestyle, it was all 100% better, all of it. So, getting around the kitchen, I wear it all day, every day.
Mm-hmm.
He told me that, you could just kind of get into this, wear it 2 hours a day, then 3 hours and 5 hours. I wore it first day, all day.
Okay.
One of the things that I'm currently doing,
Typical guy.
yeah, typical guy.
Right,
If
typical guy.
you notice, my legs are almost the same size, close. This one is about, maybe I've lost a ½ inch. What I do every day is I get on my strider in the morning and I stride for 25 minutes to keep this leg strong, because you lose your legs, you're gonna lose everything. Then you're toast. So I get on that strider and I work it, and I be sure that I don't miss a day. And that's very important. Exercise.
One
Don't ask me
question.
about diet, because I eat lots of pizza.
Over here. Go ahead.
This kind of goes into what you were saying. You said the first day you wore it, nonstop.
Mhm.
After like that first week, do you notice any irritations, redness? I know that you're wearing the long sock. Is that something you kind of have to do before
Yes,
you ever?
and that's just to keep the irritation down.
Okay.
Now, the one thing I am getting right on the back of my big toe, a little bit of a bone spur. And that bone spur is, the body is compensating for all the rest that's going on. And it says, hey, this guy needs a little bit more balance or whatever to support that big toe.
So if I had to change something regarding his prescription plan at this point, what would I be thinking? What's the first thing going through my head when he says his great toe is having trouble going into probably dorsiflexion, right? He's got a bone spur there. What would I do? What could I conceivably do with the brace? What changes could I make to
Did you
it?
add like a pad on
Well, if the shoe's crowding his foot, I could probably pocket the top of the leather, the toe box. If it's more as a result of going to extension during the late stance phase, what could I do to change the mechanics of the device on him so that it mitigates that to some degree?
Maybe use that for more selection.
You could allow for more dorsiflexion, so where where it can bend up and fold away. He's got plantar flexor strength, so he's going to be pressing down. What happens to the shoe at late stance phase? What's happening to the forefoot of the shoe? What are we doing? Right? So that position right there might very well be the position that he's going into. What would I do to the toe?
Maybe reinforce the toe.
Probably, to do it properly, what I should do is I should make the whole foot rigid, the whole shoe bed rigid, and rocker the toe. So that it can't fold up if it's rigid, and then there's a rocker so that he can walk past it to get that nice smooth rollover during gait. Okay, so that's that rocker sole that he can walk on and allow for that nice smooth rollover for the 3 rockers of gait. Okay, yeah.
How many modifications have you made for his?
For him, very, very few, other than him snapping things in half.
When I break it, he fixes it.
Yeah, yeah,
But no
those days.
adjustment as far as gait or flexibility or any of that.
Surprisingly, no irritation against the skin.
None.
When I build this, if you feel the proximal lateral aspect of the shell, you'll feel that there's a little bit of a pocket for his fib head up high, right? So the fibular head is already pre-relieved. That's usually the spot that people get pressure, and or the inferior aspect of the patella where they're kind of dropping in. Again, I get way under that calf belly, and it's really helpful to be able to load there and lift him up as well. He's not loading the patellar tendon significantly to be the patellar tendon bearing AFO. It's really a calf weight bearing AFO that happens to extend up to the patellar tendon. Yes, young lady.
How do you deal with things like hygiene and stuff for like something that's being worn constantly all the time?
I take showers.
Like washing.
Clean
No,
the brace.
I spray that every now and then with Lysol disinfectant, and
Okay.
same thing with my shoe.
So I don't
Sure.
recommend bleach.
No,
I
just
get people away from that. Anything that's going to break down glue is not a good idea. So rubbing alcohol is a great idea in general. Not dousing it, but maybe just a mist of it, and then scrubbing it down with some rubbing alcohol. I don't necessarily recommend soap and water because that can cause damage to the glue and the foams. But generally, just wiping it down, and the sniff test is a great way of telling if you're doing a good enough job. If your shoes smell, spray them with Lysol, guys, or do something.
right.
Some rubbing alcohol, 90 proof rubbing alcohol down in there will kill that bacteria. So regular cleaning is critical. The sock is really the key to basically create that barrier between the patient. Now, another thing that I tend to mention. When I was telling him how to wear this thing initially, he had to use socks. And in prosthetics, you'll get more of this from me. But this is like a prosthesis, okay? This is like a combo. Just really treating him like he's an amputee, then just working around what he's got down below. And in that way, and what I expected to have happen is for him to lose size. He was probably going to shrink because of what? Lack of use, right? So you're expecting he's not going to use that muscle nearly as much, and you're going to get some size production. Also, and what was one of the key things we had to wait on? What did we have to do initially? Tight sock.
That's right.
He had to wear a compression
That's right.
sock. He had to wear a tight Ted
I
hose,
forgot about
basically.
that, yeah.
Yep, because
That's
he had
obvious.
swelling. I came out to his house, I was about to cast him, and I put my thumb right on his shin bone, and I pushed right here on the face of the tibia, and he dented dramatically. You see anybody dent right there, so he's carrying a little bit of fluid, right?
Yeah, but not on this one.
That one, not now, it's all squeezed out, right? But when I saw him, I pushed on it, it was like created a 1/4 inch dent.
I forgot about that.
So it was instantaneously, I knew I shouldn't cast that day. Now, of course, that can really upset someone that's really motivated and want to do it. He wasn't. He was like, oh, it makes sense because he gets it. So if you have a patient that's got edema and you know it's going to go down quickly, you got to put that sock on them, the compression hose, and make sure that they use it properly. Now, when I came back out the next time, a week or two later, I've got all the fluid out because he's compliant for the most part, other than wearing the brace full time when he wasn't supposed to. And he shrunk down, we casted him, and we were able to make the device. So volume is key in this device. It has to be the right volume. To get back to the socks issue, as he would be wearing this, he's going to reduce in size because of the atrophy and because of just the sheer compression of the device. And what would you have to backfill? If he can't tighten those straps anymore, and if those edges are butted up against one another, what does he have to do in order to make it fit right?
Can you add cushion to
More
it?
socks.
Add cushion or
More
socks.
socks.
You're gonna hear me in prosthetics ridiculously go over sock plan management. That's essentially a prosthesis. It's an orthosis, but I call it a prosthesis because of how it acts and how they have to manage it, they being the patient. He has to manage it with socks, and albeit at this point he's not having to manage it with socks much because his volume is staying relatively neutral. Okay, relatively stable.
That's the plan.
Yeah, and that's great. That's fantastic. It's less effort on him, but normally you're going to have socks. So when you go out in the world and you see this patient and they are not, kind of get back to one of the points I was making, they're not going to have this long hinge that they can open up almost invariably. They're going to have it designed in a different way. You can look at some textbooks. There's different ways of designing these things. That has been what I've found to be the most effective design to hold the shells in place, because you can't have them slip past one another, and to open it up and they can get their foot through. Okay? So a nice long parallelogram, if you will, so that they can open that up and get their foot down in there. All right? But you won't see that in many places. I don't know that it's spread throughout the nation at this point. Yes?
Does your mom's hinge the other way, right?
It might. Did I reverse it?
Yeah.
It's kind of moot, right? It's kind of moot. It does not really matter as long as it can pull
As long
away
as
and
you
you
get
get
your
it
foot in.
open. Yeah.
So there's no really advantage to that?
No, I haven't seen one, with designing them either way. So, but what you'll find is that the other designs will have like one hinge point where it's really difficult to get them apart. Other guys will put these big swooping trim lines where there's supposed to be a notch where it kind of locks in, and they just don't hold. So a very, very positive strut in there that's very strong with that steel bar. That's aluminum. I think it's aluminum. Yeah, it's aluminum. That's holding that in place, and that's super important when you guys see your patients out there, that those two pieces lock together and compress the patient properly. So let's just watch him put that on. So initially he gets it. He's obviously extremely, he goes so fast because he's so good at it. And having telescoped him out of it a little bit to make sure he doesn't load it much, that's another important thing. And again, you can put the screws on the side so that you can telescope it after the fact, but I intentionally just telescoped it is what I thought 3/8 of an inch would be enough. And obviously he's gotten a lot of relief, so.
It is, it's important as to which one you do first, and the reason is the way they fasten back here. If I do it opposite of this, I can't get them loose because of the way just the way they fit back here.
So he's doing the bottom first to kind of get up under the calf belly, and then he doesn't put a ton of pressure at the top.
Nope, I just make sure it's straight.
All right.
Done.
All right.
We had to readjust this one. We moved from here to here
Yeah.
because this was pulling it straight and it needed to pull it down. That's the only adjustment we did.
Yeah, we only just basically and gave him a little bit beefier strap at the top. We had some 1-inch ones there that were wearing out prematurely,
Here we
so we
are.
put 1.5-inch stuff. And yeah, really kind of lucky to have it work that well right out of the gate, because those are really intricately fit.
And if you
and
remember
more than
that
likely
picture-
bother the people.
That where I was in traction, that's the way I was.
Oh, jeez, right?
for 6.5 months.
There's the other picture you didn't see.
So, wow, that was fun.
There's a
Do you have any
side.
complications from that, from being in the bed for that long?
There's lots of stories that go along with that. No complications, no.
prior.
As far as physical.
What do you call that, Bryce?
That's an
And
ischial
when you
weight
walk
bearing
with the brace,
KAFO.
you use the
Issue of weight bearing KA.
How
Just-
about therapy after you
Oh,
had
Lord.
the leg?
Therapy, yes.
How long were you in it for?
Well, I got back to flying. I was in therapy after they put me back in that, where is it, that, the brace. I guess I was in therapy for about 3 months. And as part of my, you guys are too young. Anybody remember Paul Johnson, heavyweight wrestling champion, back in 1967? Wahoo McDaniel? I used to play handball in the handball court with my brace with those two huge people. And they took no mercy on me. That was part of my therapy. Yeah, it had a little clip here that I could unlock, that I could bend my knee.
All right,
Otherwise
so
it's straight.
speaking of it, let's look at the
Up
camera
3
up there. So you can see laterally right here where it's, looks like it's in contact. And did you just say you had drop locks on it? Did you
Yes.
have,
Yeah,
so,
there was no contact going down.
right, so no contact going down. So it almost looks like it's touching him here, but it's not. There's a considerable amount of gapping right there, but that's pretty much necessary to be able to get up to the joint. And the joint is so long that you have to contour it back to the calf here. So that contour is not unusual to see in a KAFO. It's just because the length of the joint didn't allow the bend to go too fast. You make the bend too fast, it gets weak, it breaks. Especially in an ischial weight-bearing KAFO. And you can see it's got the laces, right? And now I can't tell how the top was made. What was it made of? Was it all leather? And was there a metal?
You mean up
Yeah, way up underneath
steel.
your steel.
Oh, absolutely.
And at the
And it
top
was
was covered in leather and
Leather
padding.
Covered, no padding.
No padding.
No padding.
Tough, dude. Okay, imagine sitting on the edge of a metal chair and just sitting there, because that's what an ischial weight-bearing KAFO does. That's where this thigh section really needs to be super supportive, and I would have probably made it a little bit longer down here to get more thigh in it, to try to get
that's
more thigh bearing.
52 years ago.
Right? So those are the kind of changes I would make. I want to cover as much as I need to make make it work, but as little as possible to keep down the contraption factor. Now this is the other part of this whole thing. You won't see many guys being treated with a PTB AFO for his condition, because it wasn't obvious that that's what a lot of people would be in a solid ankle AFO. Let's just restrict his range of motion. But the key question I asked is, does it hurt just standing? And the answer was yes. So I have my answer, right? How to lift him off the ground. Yes.
So when you're fitting for it, how do you accommodate? So it has to hold him up by his calf, but I assume you want his heel to hit the floor of the shoe too, correct?
Yeah, I don't have any idea how much pressure he's putting in there. But I do want some pressure.
At least contact.
Yeah, contact so he can feel the ground a little bit. But of course, he's getting all that kinesthetic feedback is coming up through the shells of the brace onto his leg, and he's still getting all the pressure through his joints proximally. But he's happy to have it non-weight bearing entirely in there.
Yeah, right about there is where I first start feeling.
So his
The ground.
heel, he's telling us his heel's off the ground.
My heel is off the ground that much. I started, I had a foam insert that I put in there to maybe cushion it. And Rick said, well, you don't really need it because you're up off the ground anyway. And it was right. I did not need the cushion. So, yes, ma'am.
So just depending on how much pistoning we do out of that, how much we telescope, and we're going to get that amount.
Can you describe your eval that you did with him as far as like structural inspection?
Yeah, like of his foot and ankle?
Yeah. just
Well,
like-
I didn't see any x-rays, right? I didn't have anything extra. And my critical question was that one question.
Right.
Do you have pain upon weight bearing? And then I asked him, how much range of motion do you think you'll need? And of course I cheated, right? What did I put on? I put on the range of motion joints where I can play with the pin settings, right? And the ankle. How's that feel? Where's the other one? The other one. So, in my mom's, what was my concern with her? My concern was obviously trying to get weight out of her foot and ankle because she was in extreme pain. But what kind of joint did I put in? That's a standard stirrup joint that I would have to grind the metal to make it have range of motion. Why did I use this? So that I could keep the weight down. She's not real, she was getting older and having more issues, so I was trying to make it as light as possible. But you notice, these are not light, are they? Right? They're not, yeah.
8 pounds.
Heck no. 8 pounds. So not light at all, especially when you start putting extended steel stirrups and doubling up the thickness of the metal. Lots of things going on to make it heavier. He has steel sidebars. This one has aluminum. Okay, those are all aluminum. His are steel. So we made this thing as beefy as we felt we needed to, given his, and especially given his activity. So as he's twisting, we found out very shortly that he was snapping these things and he needed to change.
So did you like analyze his gait? Did you make him stand? Did you like what types of exams did you do?
Yeah, those are great questions. She wants more definitive measures.
Gotcha. He made me walk from here to there.
It was really obvious to me.
Yeah, it was.
What I needed to do. Because I know you want that test, and I know you want that full eval.
There was
I didn't
none.
do a full-blown eval. I did all my documentation. I muscle tested him. He had full strength in the quads, and But the critical question was pain during weight bearing. So all of my, and I could probably maybe I should bring the eval in since you've been in here and sharing. I can share that eval with you, and you guys can see what I write. But I really, I'm just ticking boxes because I know what he needs.
So like, because we're inexperienced, if we were to break down the biomechanics of the foot, like seeing it from your eyes, what are we looking at?
Yeah, you wanna test all the joints. You wanna know the range of motions, where the pain is. That's one of the key things, right? So if he's got all this pain in more than one joint, we need to assess what do we need to do. Just like I was talking about with this great toe, if it's painful into dorsiflexion, there's a change in the prescription plan. So yes, you want to document what hurts and why, or what's weak and why, and then you and I get together and we formulate a plan regarding that particular situation. But I will bring in the eval so you can see what my eval looks like. Go ahead.
When he didn't do an eval, I'm fairly familiar with physical training, orthopedics, and things of that sort. When he didn't do the eval and he said, "I can fix that," that's when I said what I said, because I didn't think he could, and he did, and it's awesome. So.
Go ahead. Thank you.
Have you had any trouble since you doubled up on the steel and the stirrups? Have you broken any?
No.
No, got lucky, yeah. So he has not overpowered that yet.
And I have played golf with it. I got a hurt shoulder right now, but and I swing hard, and I swing often.
That's not a pound, nearly a pound of metal.
But I'll tell you, it's truly a life-changing thing that Rick and Bremer has provided me. I may be one of a million success stories, but it's my success story, and it's awesome. I cannot tell you how thankful that I am to have this, be able to use it every day.
Awesome. Thank you. You're welcome. Yeah.
Well.
All right, so any other?
I have one question,
Yes,
just real
please.
quick. Because you mentioned that you were in pain for 14 months because your doctor wasn't aware of the potential orthotic. What did your doctor recommend? Like, was he just like, there's nothing
Surgery.
That was it?
That was
there
it.
was no like referral or anything?
He was wearing a little ankle lacer
Right.
when I saw him.
Yeah.
Still rolling his ankle.
Yeah, and it
He was like, you're just gonna be in pain or you have to have surgery?
Yep.
Wow.
Exactly.
So you will have doctors out there, that's what they do. They're trained to cut, okay? They're trained to be carpenters inside the body. I'm trained to do everything from the outside, right? So that's why you bring in specialists to do different things, is you bring in the whole team. Now, it was just sheer serendipity that we ran across each other, the God tap, right? So it was just by luck, and we ran into each other, and
There you are.
there it is.
Well, I did ask the surgeon when we were discussing ankle replacement after I had this. I asked him, if I do ankle replacement and fusion, what is your percentage of success? And he said,
30%.
what, give me?
30%.
30? Anybody else? 30 was close. He said, well, maybe around 50 or so. He said, I replaced, at the time, 12 ankles. All were successful down in Flagler County. I said, 50% is pretty good, but you watch me walk, this is 100%.
Yeah, and
And he said, call me when you need me.
you know, and granted, he loses the surgical case, but obviously if the patient's happy, that's what we're happy with,
Sure.
right, as clinicians.
Yep.
So absolutely fantastic to have you here, sir. Thank you so
It's my
much. I
pleasure.
appreciate it.